So I want to welcome everybody to Pediatric Grand Rounds. I'm going to turn it over to Dr. Anda Quo to introduce our speaker for today. Anda.
Great, thank you. So I'm incredibly thrilled to introduce Sarah Tilo Roberts. She's a nationally certified healthcare interpreter and a staff medical interpreter at UCSF. Her upbringing in a bilingual family with a strong passion for human rights work has really informed her approach to interpreting. And in 2011, she attended a workshop where she learned how interpreting can be applied as a tool for social justice and social change. And she strives to carry these lessons with her and is really eager to educate others about this approach to interpreting. And on a personal note, as someone who's working with others at our institution to build the infrastructure to support community partnered research as a critical component of equity, I've been incredibly fortunate to have worked with Sarah and other colleagues in the context of the Patient Community Advisory Board we developed for the state's California ACEs Learning Quality Improvement Collaborative. And I really felt like and feel that as a healthcare provider and in my other UCSF roles that we have tremendous opportunity to partner with interpreter services across our institution's mission areas of clinical excellence, research, and education. And just really excited for this presentation. Thank you, Sarah, for sharing your time with us and expertise.
Thank you so much, Anda. Let me share my screen. All right. So let's get started. So I just want to go over the learning objectives again. In this presentation, we will be talking about how interpreting services are fundamental to the mission and vision of the Department of Pediatrics, and identify how partnering with interpreters as subject matter experts can support the patient care goals of providers, as well as give examples of best practices for partnering with interpreters in the areas of research, education, and patient care with the overarching values of social justice and health equity. So a little bit about me. I grew up in a really awesome family. My mom is a lifelong human rights activist working with Colombia. My dad got involved in Central American social movements in the 70s. And from a young age, my parents really just exposed us to all the work that they were doing. They would have meetings in the dining room and everyone would sit around the table and we'd be welcome to come through and scribble on our notepads, pretend to be taking notes. My entire upbringing was bilingual. So both at home and then elementary school, fully bilingual, which is really such a blessing. And also we are a family of interpreters. So my dad is a translator and interpreter in DC, and just by chance, me and my brother have also become interpreters. He works in the court setting, I work in the healthcare setting. Just some pictures of my family. One person here is not my family. This is actually my dad interpreting for Ruth Bader Ginsburg, which is very cool. Next slide. So I did a workshop in 2011 that was really fundamental for me. In that workshop, I learned that interpreting can be so much more than just transmitting a message. I learned about how to create multilingual spaces and what that really means. And also knowing that good quality interpreting is fundamental to creating those multilingual spaces. And a big part of creating multilingual spaces is decentering English. So we live in an English dominant society, and that is often our default. But when you're creating a multilingual space, it's important to not assume that everyone is going to be speaking English, and it's important to cater to that. So we learned some tools for how to do that in this workshop. So in the workshop, we touched on all of these different themes, with interpreting at the center, and then expanding out to language access, which includes interpreting, but goes a step beyond that, where there's more, there's availability of interpreting. The organization knows that it is needed and it's present. Language equity goes a step beyond that, and it talks a bit more about the idea with language equity is that it's a bit more ingrained in the institution, this idea of language diversity. And then language justice is this big, big, beautiful idea that I love that I'll explain a little bit more. So just to give some more definitions in this context of thinking about social justice and interpreting as a piece of that, and language justice. So interpreting is the verbal or visual transmission, if we're talking about signed languages, from a source to a target language without adding, deleting, or changing anything. Language access, the organization has access to interpreting services and translation. However, language services are often thought to be for non-English speakers. Language equity, the idea here is that English is not the default language. Materials are available in the languages of the participants. Interpreting is available for all languages spoken. And then language justice is this really beautiful thing that is so expansive, and the definition of it has continued to evolve over time. And I have some really amazing friends and colleagues who work in North Carolina who have done a lot of work on this idea of language justice. So I'm just gonna go to the next slide. So this is a quote from a good friend of mine who was also in this workshop and has done a lot of work in North Carolina and done a lot of community organizing and movement building. Language justice is not just about being able to speak in our chosen language. It's the radical assertion that one needn't exile any aspect of their cultural and language inheritance in order to be heard. Language justice is the creation of tools and strategies for survival and transformation. It's ending systems of oppression, white supremacy, and colonization. It is cultural work that allows us to exist in our full identities and heal centuries of trauma. Language justice is a table that all of us are welcome to. You are always home here. So I think what's so great about this definition of language justice is that it also includes English, for example. So obviously I'm talking about interpreting, and my languages are English and Spanish, but language justice is something that can be applied to even a single, or something that can be thought of as a singular language like English, which has many different ways of being spoken. So the idea is that people can show up to spaces and they can speak the way that they speak that might be informed by their history, their ancestors, many of the things mentioned in this quote, and be received and taken seriously and welcome. And in the context of interpreting, the idea is that very similar, is that people can be received and have a conversation and be engaged with and engage meaningfully. And in order to do that, obviously in that case, you would need interpreting. So in 2018, I became a medical interpreter at UCSF. And this was my first time working full-time as an interpreter. It was really great. It was pretty lucky. I went to a language agency and they said, would you like to work full-time at UCSF? And I said, oh, absolutely. That sounds great. I didn't even really know what UCSF was, except for that it was a hospital in San Francisco. And I was so lucky to have that opportunity. When I got started, I was working mainly at the Mission Bay and Parnassus campuses. And it was really amazing just to get the experience of these two huge hospitals, and so different. I got to go throughout all the clinics, all the inpatient units, both at BCHSF and at 505 Parnassus, and just get to see all sides of the hospital. Another thing that I got to notice was that there just felt like there was a lack of consistency throughout the medical center between how different providers were working with interpreters. And I really got the sense that every clinic was really siloed when it came to their approach with interpreters. So I'm going to talk a little bit about the way that medical interpreters are trained. So in our training, we are shown this pyramid, and the idea is that we are supposed to stay as much as possible in the role of conduit. Basically, that's where we are just straight interpreting. We are not doing anything else. We are transmitting the message from one language to the other. And then if need be, we are asked to clarify if there's a point of clarification that's needed, whether it's like a language thing that didn't come across quite right, or it could also be a small cultural thing. For example, in Spanish, there are many different kinds of Spanish spoken throughout the Spanish-speaking world, and there might be different words for different things, different body parts, things like that. So that would be an example of maybe when one might need to clarify. And then we have cultural broker, which would be like the next level of escalation, which could be more, the idea there is that maybe there is more of a cultural thing, which could be, again, something sort of like the different names for body parts, but it could be like a food thing, or it could be a ton of things, the cultural brokering, just because there's so many cultures coming together in the interpreting encounters that we do. And the very last part of this pyramid is the advocate. And the idea here is that very rarely are we supposed to advocate. And the idea too is that as soon as we're done with our escalation in the pyramid, we go immediately back to being the conduit. The reality of the medical interpreter is that we're kind of doing all of these things at once. So it's easier to stay in the conduit role when a provider knows how to work skillfully with an interpreter. And one example of that would be, sometimes a patient will not understand something, or they'll say, I didn't hear what you said, or what did you say? And a skilled person who is skilled in working with an interpreter will know that it's not the interpreter expressing their own confusion, and won't then try and start clarifying with the interpreter. They'll just, realize that that is the transmission of the message from the patient. So they'll continue to engage with them. We're constantly listening for understanding, which is really hard to do while you're also interpreting, to see if clarification is needed, to see if things are being understood, and to make sure, just to make sure that things are being understood going both ways. And then we have to be attuned pretty much all the time to cultural cues and how they influence communication. That's pretty much always happening in the background. So the role of advocating is really challenging. And, I do agree that is something that should not be done constantly. I mean, hopefully the need for it doesn't arise constantly, but it's definitely the hardest of these skills. And it's really important that it be navigated skillfully. And it really depends on the circumstance. I have some examples that I'll come to later on about how that can look in the clinical setting. So working with pediatric patients, as I mentioned, when I started at UCSF, I was working both at Parnassus and at Mission Bay. And so I really got to see the difference and experience the difference of what it's like working with pediatric patients versus working with adult patients. And in the pediatric setting, you're pretty much always working with families. And there's typically different levels of English within a family, especially if the kids are born here. And depending on how old the kids are, that makes a difference. And depending on how many kids the parents have, often if the parents have a few adolescents or something, then those parents might have had more of an opportunity to engage with the school systems and with other systems through which they may have had more exposure and more opportunity to deal in English. And something that's really true for a lot of immigrant families and a lot of folks who have these different levels of English within their families, that children often carry the burden of interpreting for their parents from a young age. Also, parents are stressed. I think most people know this, but your kid is sick, you're already stressed, you're not sure what's going on. And on top of that, you have this language barrier and all the cultural barriers that come from being someone who's not skilled or experienced in medicine. You're coming into the hospital setting, and it's just a lot of stressors stacked on top of each other. So the mission of the Department of Pediatrics are these things, and the idea is that they all rest upon the social justice and the social justice and health equity platform. That's the foundation. So just to remind folks, I'll read what that part of the mission says, the social justice and health equity. We strive to make social justice and health equity the foundation upon which every pillar of our work rests. through a commitment to examining our practices and breaking down structural barriers that exist in research, education, and healthcare. So I just kind of want to take a few minutes to talk about these other mission components and sort of bring in the lens of language justice and that way of thinking and applying interpreting. I don't have a ton of experience with the research side of UCSF, although Anda did remind me that I do have experience working with a particular research initiative. But in general, I have also in the clinical setting had a lot of experience interpreting clinical trial consents and mostly things of that nature. And usually the patients get their Bill of Rights in their language, and that's kind of it. And I've heard people say, it's really expensive to translate these documents. And I guess I just want to pose the question of how can the idea of language inclusivity be brought into the fold when research projects are being developed and not just be an afterthought? The next point is educating and training the pediatric leaders of tomorrow. So I actually had the pleasure of participating in some trainings with some second-year medical students where the students got to practice working with an interpreter and a limited English proficient mock patient. We had these actors that were really great. So we did some role playing and it was really awesome. It was a really great opportunity for these students to practice these skills and to get feedback from their classmates, the interpreters, the actors, and their instructors in this classroom setting. And it was really important for them to have a better idea of how to work with interpreters. And it was role playing, it was a little silly and a little awkward, but I think it's so important to provide those safe spaces so folks can feel comfortable and more confident going into the actual clinical setting and working with an interpreter. Aside from the basic things that a lot of people are told about, when you're working with an interpreter, sit in a triangle, speak in short phrases, that kind of thing. Opportunities like that, where you actually learn how to work with an interpreter as part of the curriculum is so important, because then you have young doctors coming into the field with that knowledge and they can share that with their colleagues. They can share the tips that they got from the interpreters and share how those tips actually really help them to connect with their patients and have meaningful conversations where the barrier of language is really lessened, and speak directly to the patient instead of saying, interpreter, can you tell them? Because that can be really dehumanizing. And so I think it's really important and needs to be thought of as a fundamental part of the medical education, whether we're talking about physicians, nurses, pharmacists. I think everybody who works in medicine and in a patient-facing position needs to learn from those mistakes, needs to learn how to work with interpreters and have the opportunity to practice and make mistakes and learn from those mistakes and feel what it's like to have a successful encounter where you click and where you're really talking with and connecting to your patients. The next part is leading clinical care that transforms the lives of children. And here I'm going to go into a few clinical examples. So there's so many experiences that I've gotten to have and that my colleagues have had just out in the field interpreting. And so it was a little hard to choose a few, but I wanted to make sure that I chose some that would, kind of touch on some of the points of the different roles of the interpreter and ways in which providers and clinicians can partner with interpreters. So example one actually took place at Parnassus, but it was a mom and her adult daughter who is a younger adult. So let's go into that one first. So in this example, we had a mom who was at the bedside with her daughter, and her daughter had had meningitis and she developed hydrocephalus and she had an external shunt. When I got to the bedside, the mom was there and she was very polite and very kind to me. I introduced myself and I noticed that her Spanish sounded a little bit different to me, but I wasn't sure exactly why. So I just kept listening for that to see if I could place it or if it was something that I needed to pay attention to. And the mom was speaking Spanish. She was very enthusiastically speaking Spanish, just so grateful, expressing so much gratitude and appreciation for the care that was being provided to her daughter. And I got the sense that in my conversation with her and just in like polite bedside conversation with the nurse, that she was understanding most of what we were saying, but maybe not all of it. And this is a good example of cultural competency, or that cultural brokering, because I was starting to think that maybe this woman's first language was perhaps an indigenous language. And I know that in Latin America, as well as this country, indigeneity is looked down upon, and indigenous languages are discriminated against. And so and a lot of people are not taught to be proud of those cultures and those languages. So I was starting to think about how I could ask the mom if perhaps she spoke another language, and just wanting to do that really skillfully and politely. And while all that is happening in my head, the nurse started explaining the basics of a VP shunt procedure to the mom, since the doctor would be coming by soon to do the consent form. So the nurse explained that her daughter couldn't live with the external shunt, so they're going to put it inside her body and it would drain into her belly. Now, the word belly is really hard to interpret because it can mean stomach, it can mean abdomen, and in this case, it can mean peritoneal cavity. I interpreted belly as stomach because I sensed that the nurse was trying to keep the language accessible, which I appreciated. And the mom very politely said, "Oh, no, I don't think that'll be good for her because the water will be flowing into her stomach and she'll always feel full and she won't have a good appetite. So I don't think I want to do that." And immediately it was clear to me that she had not properly understood, and that I could have made perhaps a better choice with my words, including I could have chosen to clarify. And perhaps the nurse could have chosen a different word as well. But again, I think she was trying to make something so complicated like a VP shunt a bit more accessible. But I still thought the best thing to do would be if I could find out what other language this mom spoke, so that for the actual consent, she could have an interpreter in her indigenous language, just to avoid any further confusion and potential stress. Because I know from experience that when there's a misunderstanding, it can get really compounded if you just keep trying to clarify via the same route that the confusion happened initially. So I was thinking the best thing to do would be to ask her about her other language. And so I did. I politely asked her if she spoke another language, and if she would like to if we could find an interpreter in that language. And I made sure not to put the burden of clarity and understanding on her, and mentioned that it could be good so that the doctor could explain herself more clearly, and just to make sure everything was crystal clear. So I was trying really hard not to alienate her. I wanted to respect her and her intelligence, and also just see if there was something that the hospital could do better for her. So I called my supervisor. I asked her politely. She told me what language she spoke, and I called my supervisor, and we were able to get an interpreter from her native language. And I left. I had to run off to some other part of the hospital, but it was in the back of my mind all day. So eventually I came back to the unit and I checked in with the doctor and with the nurse and with the mom, just all separately and very politely. And it sounds like everything had gotten cleared up, and the mom had a much better understanding of what the VP shunt procedure was going to be, which was obviously critical. So that was a big one. Let's go to the next example. So I love this clinic, the Child and Adolescent Gender Clinic. I don't get to work with this clinic as often as I would like, but when I do get the opportunity, I'm always really thrilled and delighted. And I think that, I think by this point, a lot of people understand that access to language and gender inclusive language is essential for delivering gender affirming care. And the question of gender neutral language and gender inclusive language in Spanish is really challenging. Spanish is a very gendered language, and so that presents a challenge when it comes to trying to find language for folks who might be non-binary or gender non-conforming, or not want to use gendered language to describe themselves. So as an interpreter, I feel like it's important for me to try and stay in the loop of how language changes to suit the needs of the speakers of that language. And inevitably this happens. And I think that's one thing that's so beautiful about language is that, you know, we have these organizations, like in Spanish, it's the Royal Academy of the Spanish language, that sort of are trying to mold and keep the language standard. And I think that is really important. And language just keeps changing because people need it to, because people need language to reflect them. And I just think that's such an awesome thing. So I feel like it's really important for me to stay in the loop of how these changes in language occur, and when there are shifts in the language that pertain to certain cultures or communities. And in this case, we might be talking about the broader queer community or the trans community, however you want to look at it. And to me, this is another point of cultural brokerage and cultural competency, and just expanding the definition of what culture means, because this is not this point in the language is not something that's specific to the Latino community per se. It's a bit more niche than that, and I think that type of cultural competency is super important. So I really try and keep my finger on the pulse of this gender inclusive language, and my dad's always sending me interesting articles if he comes across them about such things, because I think, again, as I said, as interpreters and as people who are socially conscious, I think it's important to stay aware of those things so that when I am interpreting for families, I can use this gender inclusive language. And in doing so, I hope that I can affirm their child's gender and that they can hear what a gender neutral pronoun and gender neutral language sounds like in Spanish. And for that kid, they can hear that there are ways of expressing themselves in Spanish if they choose to do so in their culture. And I think that's really important to integrating the different parts of oneself, especially at that age, but really at any age. The third clinical example I have is in adolescent medicine. And this point is not unique to adolescent medicine, but I've had a particularly great success, I would say, in offering some suggestions to some of the providers in that clinic about how we can have a better flow, considering that there are adolescent patients who are speaking English primarily, and their parents would prefer to speak in Spanish and have an interpreter present. And the provider obviously is speaking in English and also needs interpretation. So when you're a teenager and you're bilingual, it's really hard to pause and to ask, to pause and be like, okay, I'll let the interpreter go, because then you're hearing everything twice and you're already a teenager and you're like, why am I hearing everything twice? And that can be really challenging, because what ends up happening is that the providers and the adolescent patient start having a back and forth, which is really important. I think one thing I really appreciate about UCSF is wanting young people to take kind of ownership and responsibility over their healthcare in a way that I think is like developmentally appropriate and all of that good stuff. So you want the adolescent patient, you want this, and they might not even be adolescents, they could be like, 10 or younger, and just really chatty kids. But you want those kids, you want those pediatric patients to be engaging directly with the provider. And it's so important that their parents stay in the loop of what's happening. And especially, in the adolescent medicine clinic, where the parents are really being asked to take on a big and new role in the care of their children. And it's really hard, just like going back to what happens when that conversation starts out and the interpreter isn't necessarily included from the beginning. what I'm doing, I'm basically sitting on the sideline. I'm noticing that the parent is not engaging. I'm noticing this back and forth between the providers, and I'm waiting for my moment to like jump in. And it's so disruptive to have to do that, because when you start interpreting and then people just start talking over you, it's, you know, it doesn't feel like it's going to work. So usually I end up having to be a bit forceful and kind of like asking if we can take a pause and if I can just explain my role and things like that. And then I'll ask the parent, you know, to make sure, like, are you understanding what they're saying? And they're usually like, I would really like it if you could interpret. And I'm like, great, I would love to. But something that works out much better is actually having the provider to be able to establish this at the very beginning of the appointment. And I've had a really good success doing that with one of the providers in the adolescent medicine clinic. And so what that looks like is at the beginning of the visit, that provider will, you know, they'll check in with both the parent and the patient, and they'll say, you know, nice to see you guys. Hey, patient, like, I know you speak English, but we just want to make sure that your mom is, you know, kept in the loop of our conversation. So if you could just wait after I say what I'm saying, wait before responding, and let the interpreter interpret so that your mom can be included. And I find that that works way better than having me do it. I'm happy to do it, and I'm happy to establish that at the beginning of appointments. But, you know, in this case, the providers already have a relationship or in the process of building a relationship with these families and these patients. And it just feels like it's gone so smoothly every time, since we've been able to establish that that's a good way of doing it from the outset. And so I just think that's like a really awesome example of one thing that has worked really well. And again, I think it's something that doesn't just happen in adolescent medicine. I think it can happen throughout all of pediatrics. And it's really tough to be in these appointments where it feels like I so badly just want to be interpreting, and for whatever reason, the provider will kind of not facilitate that or not allow it, usually without knowing. But it's very painful for me to experience, because I feel like these parents are just not being included in the appointment. And I just really don't think that anyone would actually want that to happen. But by not, you know, very much like centering English and not thinking about how to make the space multilingual, make it inclusive for everybody that's there, you're excluding the patient's main and most important caregiver from the discussion of their plan and of their medicine and their treatments. So that's really tough for me to experience, but I'm so glad that you know, just happened to come up with this really awesome strategy that's been working really great. I have another more specific example in adolescent medicine that I'll go into. So it's a bit of an extreme example, but this patient really didn't want to be on screen. She didn't want the camera on. She didn't want to talk. So we're primarily just having the Zoom telehealth visit with her mom while the patient stayed in her room. And so the mom was having the visit with the provider, and then the provider took as much information as she could from mom, and she was going to go consult with her attending and come back. And when we came back to share the care plan, the mom was in the room with the patient in her bedroom, but the camera was still off, and then the microphone was muted. So we were like, well, all right, what do we do? And then the provider started kind of typing they were sharing their care plan and sharing, like, you know, this is what we should do next, and here's how we're going to follow up and all these things. And the only feedback we were getting from the other side of the screen was just some chat responses in English. And I was feeling a little bit suspicious at this point about whether mom was in the room or not. And, obviously this very important part of the visit of, what changes are we going to make? What's next? When are we going to see each other again? I wasn't sure who that was getting transmitted to. So I ended up kind of saying like, hey, everyone, I'm not sure if mom is still able to hear what we're saying. So maybe we could just wrap up the Zoom call and give her a call on her cell phone. So we did, and lo and behold, the mom told us that she was locked out. Her daughter took the tablet and she closed the door and she locked the door. So the mom was locked out of the daughter's room. And she was, really glad that we had called her. So that's more of an example of advocacy. But yeah, so those are my clinical examples. So I think with all that said, I just really want to encourage everybody to think about partnering with us, think about partnering with interpreters. A lot of people were trying to change some of the language about work with an interpreter instead of use an interpreter. And I think that those semantics are very important because that's how we build like consciousness and culture within an organization. And I think that, really important to know that we are here and we are really willing to work with you guys, and we have a lot of skills. Definitely do the basics that a lot of people maybe have been taught at one point of positioning yourself properly in the room, so that you have a good chance of being able to speak directly with the patient, speak clearly and thoughtfully, and take time to check in with the interpreter, however brief, whether it's in the beginning of the appointment, just to be like, hey, do you have a sense of what we're going to be talking about, or let me give you just a little bit of information so that you can be in the loop, or afterwards, and you can ask the interpreter, just to check in and be like, how did that go? Or did you have any concerns? Or, if you have the time to do that, or if you can make the time to do that, I think it's really important. And I just want to emphasize that we are, those of us who are trained nationally certified medical interpreters, we are skilled. We are experts in this. We're trained to do this. And for those of us who are staff at UCSF, we know UCSF really well. And like I said, we get to go all over the hospital. So we have a lot of familiarity with the campus and with families too. I've had the opportunity of interpreting for an adult patient at Parnassus, and then I've run into her in the pediatric clinic with her kids. So, we really know UCSF. So that is the end of my presentation. I wanted to make sure to leave time for Q&A. Hopefully it's not too much time. But I just wanted to thank everybody for attending, and I wanted to thank Dr. Kuo for suggesting that I do this, and all of the CalQuick team that I got to work with last year. I want to thank my family and my coworkers who are awesome. And yeah, we're out here every day doing this work, which is really gratifying and challenging, but I think we all love it, and that's why we do it. So that is the end of my presentation. I'm happy to take questions if there are any.
Thanks so much, Sarah. This was really great to get your insights and hear a perspective that I don't think we hear that much. Anda, I think you have a question. Do you want to just ask your question?
Sure. So thank you so much, Sarah. That was wonderful. And I had two questions, but one is if you could share a little bit about your strategies or terminology that you learned about in Spanish in the gender clinic. And then the second question I had was if you speak another language, but not fluently, and want to work with the interpreter in a way that's like effective and efficient, or I don't know what the right word is, like, so we'll say like use it as backup, so to speak. Is it better just to like not acknowledge that you understand what the patient said and just let the interpreting happen, or not to interrupt the flow?
That's a really great question, and I'll start with that one, and definitely come back to the question about gender inclusive language. I think that comes up a lot, especially with Spanish, because we're here in the Bay Area, and a lot of people just have had the opportunity to be exposed to Spanish or have studied it at some point. And it's really, really the best thing to do is to let the interpreter interpret everything. I think that is the easiest thing to do. I think a lot of folks are maybe wanting to connect culturally or show some cultural competence by doing that. And I think a polite way to do that, if you have a standard intro, you can introduce yourself in that language if you're able to do so respectfully and politely. And you can say, that's it, that's all I got. Or, I understand a little bit, but I'm going to let the interpreter do their job now. Because what we're doing then is we're basically stopping the flow of interpreting in our brains, which is a very complicated process. I was told once that, typically we're using, like right now we're chatting, we're having a conversation, we're using about 7 cognitive functions. When you're interpreting, you're using about 21. So having to pump the brakes on that and then like rev it up again is very challenging cognitively. And we're able to do it, but it's super disruptive. And there are some providers that will tell me, like, I work with a couple of providers who maybe are Italian, for example, so they'll apologize beforehand and they'll say, I'm sorry, I might interrupt you because I understand, but please stop me. So having that self-awareness, I think, is really great. But, say if you understand, I don't know, 70% of a language, that means that there's 30% that you don't understand. So to avoid missing something important, I think the best thing to do is to let the interpreter do their job. And if you feel that you might be competent or proficient or fluent enough in that language to provide your services in that language, you can take an exam where if you want to be a bilingually certified provider, you can take an exam and you can be certified to do so. But to be clear, that certifies you to practice in that language. You do not become an interpreter by taking that exam and by passing that. To become an interpreter, you have to be much more than just bilingual. And then the question about gendered language, I mean, it's something that started coming up like into my consciousness even back in 2011 when I was at that workshop, and everybody at this point has probably seen or heard like Latinx. And I think that was one of the earlier iterations of people trying to find a way to make Spanish more inclusive, or at least the phrase Latino. Sometimes people use the like email @ sign because it's like an A inside of an O, but I think we're typically moving away from that. And there are these really amazing young people in Argentina who have been doing this work of gender inclusive language. And that is my dad sent me an article about those people in particular. And so one thing that they're doing is in Spanish, there's already a precedent for having words with an E at the end that refer to somebody instead of like an O for masculine or A for feminine. Like interpreter in Spanish is intérprete. And so to specify the gender, you would just say la intérprete or el intérprete. And then to deal with that question of like the la or el, you can say le intérprete. So that would be a way of having it be gender neutral. And then another thing that's tricky in Spanish is like, there's no word like child or kid. Like there's very few words like that are not gendered. And so that would be, you can implement the E at the end of like a word like hijo or hija. So you'd say hije. And that's what I like to do. A lot of people push back on that or are uncomfortable with it because it's a linguistic change, and there might be something better and new coming down the pipe. But it's something that I like because it does have linguistic precedent and because it can be applied to other words like child or something like that.
Sarah, there's a question from Jennifer Lee or Lai, I'm not not sure how to say her name, but Jennifer says, are there any trainings that providers can attend to aim to increase their knowledge of best practices for using an interpreter during visits? And are providers able to request the same interpreter for continuity of care?
Thank you for those questions. I hope that there are such trainings. I don't know of any, but I think it would be a really great thing to have. And I think that's an awesome question. I hope it exists, and if not, I think it should. And yeah, there's a lot to learn. And then as far as the question of continuity of care via the interpreter, it's kind of a tough one because, as I said, you know, we do follow these families sometimes, whether we mean to or not. Oftentimes, like, especially in the pediatric setting, if there's like a critically ill child, a lot of the interpreters will be able to go through and interpret for those families, meet them, and get really familiar with their cases. But another thing that is true about being like a skilled, trained medical interpreter, especially one who works at only one medical center, like the staff do here, is that we have access to the charts. We talk to each other about the cases, and we're able to keep one another in the loop. So in a sense, you definitely can, and there are times where I think it can be more appropriate to try and have the same interpreter. But I think in a lot of ways, it's not always necessary because of the points that I just shared. But I think it's also a really good question.
I just wanted to point out that the UCSF School of Medicine actually includes a session on how to work with interpreters in their early clinical training curriculum. So hopefully the next generation of physicians is more adapted to that than for the current physicians who I think for most of us, we didn't get any formal training on that. There's a question from Mitul Kapadia. We have a current challenging patient in hospital, which we are learning has had extended language-related concerns. The family speaks a dialect of Mixtec, which our hospital missed for a number of weeks using a Spanish interpreter, which family had minimal understanding of. We're now being told we don't have access to a Mixtec interpreter and trying to navigate how we can communicate with this family. Challenging situation, and would appreciate any thoughts you might have for more atypical languages, particularly as we didn't figure out the language issues for many weeks.
Yes, that is a challenging thing. And I think that's something that a lot of us as interpreters have also experienced. And it's super frustrating when that happens. I think a lot of times these patients, due to their surname perhaps, will just get labeled speak Spanish. And I'm pretty sure that in Apex it's really easy to just change the language that a family uses. And for example, sometimes if the patient is English speaking, but the parents aren't, someone will also maybe make that mistake and it's also not super clear. So, but we don't have to talk about like the Apex right now. It can be part of the problem, but it can also be part of the solution. And when it's true, like Mixteco is one of the indigenous languages that is highly regionalized. And so there are so many different ways of speaking it that are not always mutually intelligible. I will say that I'm super ignorant about most of these indigenous languages. So that's probably the extent of my knowledge as far as what I can share about what is and isn't understandable between different types of Mixteco. So we do have access to indigenous language interpreting, but because it's this is a language that would be called a language of lesser diffusion. I think you threw the word atypical out there just probably because that's what came to mind, but in the world of interpreting, it's called language of lesser diffusion. And so because it's a language of lesser diffusion, it means there are less interpreters. And I think that is super challenging. And that means that maybe there's one Mixteco interpreter somewhere in California that is able to communicate with this family, but maybe they're not able to work full time because it's not sustainable to them because there's not enough work coming in doing just interpreting in Mixteco. So maybe they're not available all the time because they have to go to their 9-to-5 job to pay the bills. So that's a super big challenge. And I think one of the things that was so great about the workshop that I have mentioned is that they're really encouraging folks who are bilingual or multilingual to develop the skills to become interpreters. So I think that would be awesome if somehow more folks who speak these languages of lesser diffusion, these indigenous languages that can be so diverse within a linguistic category became interpreters. And yeah, I think the question was pretty general, so I feel like I've answered it, but you guys can always follow up with me if you want.
So in the meantime, one of your colleagues posted more of an informational piece of advice to people around the UCSF Interpreting Services Management Team offering in-services to all clinical areas on how to request and work with medical interpreters. So I've put that on the chat for everyone to see with the contact information. I have a question that I'm sort of been trying to think to myself how to phrase, so I'll just sort of pose it as anecdote, more or less, from a prior interpreter that worked at the Children's Hospital who came very frequently to our intensive care unit, who told me that one of the most challenging things for him was if there was a provider who said things that weren't necessarily sensitive or maybe overly medical, or something happened in the conversation in English that he felt shouldn't be translated verbatim. And we had conversations about that intersection, right? Where can you be an advocate to do the right thing for the patient, and where do you really just have to translate what the clinician is trying to get across? And from the other side, I sometimes I understand a little bit of Spanish, so there I don't have it so much, but I sometimes sit in conversations with interpreters, and it's a cliche, right? It's the comedy cliche, but it does happen. I say something very brief, and the interpreter takes a good 3 minutes to translate it, and I'm like, is that really, are you saying what I just said, or what are you saying? So how do you see that balance between advocacy, maybe changing things a little bit in translation, and staying true to what a clinician is trying to convey?
Yeah, I mean, so for that, first I will just point you back to the definition of interpreting, which is interpreting is delivering a message from source to target language without changing, adding, or omitting. So when we go in there and we're able to have a pre-session with you guys and say, we're going to interpret everything you say as you say it, we mean it. That's what interpreting is. And that can include these side conversations. I was in a cardiology visit once where the guy had a VAD and the providers were just looking at the information coming off of it for like 5 minutes and just talking to each other. And I was like, oh man, this guy's sitting here and he's probably wondering what the heck they're saying. And this machine is keeping him alive. So maybe they could clue him in. So I think it's really important to keep that definition of interpreting in mind. And we're not trying to pester you guys or anything. And I think that's also why it's really important, because once we start interpreting, it's challenging to have to step out of that role. So things like having a check-in with the interpreter beforehand, talking about the cultural things that might be going on with that family, or if the interpreter makes that choice to omit something because they think it could be harmful, I think it's really important that the interpreter then be transparent to the provider about why they did that. Again, that kind of falls outside of the pure definition of interpreting. But, you know, we do find ourselves in very, very challenging situations sometimes that most people would never imagine themselves in firsthand. So if someone chose to do that, I totally trust that they made a choice that was informed by the context. But I think, again, transparency is really important. And yeah, I think that's a tricky question.
I think you answered it really well, though. I didn't expect a like easy answer to it.
Yeah, that's a lot of the ethical training that we get. It's sort of like, you know, what do you do in this situation? What do you do in this situation? What if someone says a lie and you have to interpret it? And the answer is you interpret it, because it's not you. It's not you speaking. It's not you transmitting your own thoughts or feelings. You are there in the service of the message.
Yeah, I hear you, and I imagine that sometimes can lead to some moral distress as well.
Oh yes. Absolutely. I mean, especially, you know, we're saying things in first person, so we're taking in a lot. You know, we're holding. There's a particularly tough case that I was part of in the CICU at the end of last year, where there was no good answer, and there was no good way to communicate what was going on with the family. The attending was, you know, experiencing a lot of moral distress, and the family was too. And I was just kind of like experiencing it all in my body as I was saying what both of those parties were saying firsthand. And yeah, so definitely some moral distress comes up.
And I think you get the last question.
Great, thank you. Oops, excuse me. I'm in my car still trying to get to clinic, but Sarah, you know, if you could reflect just a little bit on what your experience was working with us in our project, the California ACEs Learning and Quality Improvement Collaborative, with our Patient Community Advisory Board. And because it's out of the clinical realm, and this is what opened my eyes up to that there's a whole partnership out there with interpreter services in our other mission areas that maybe is underutilized. And I just would love to hear your perspective on working on that project and what role you feel like interpreter services played in that project.
Yeah, I would love to. That was such a great experience for me. So I had the opportunity to, I was asked if I would want to do some simultaneous interpreting, which is where it's basically live interpretation, but everybody gets to choose which language they're listening to. So, which is different than what we typically do in the clinic, which is called consecutive interpreting. And I joined the first meeting, and I think it was a little bit challenging because it was a really beautiful and diverse group, and there was English speakers, there were Spanish speakers, there was other kinds of diversity as well. But it was challenging to figure out just the technical side of how do we make it so that we have interpreting on Zoom, which is something that is possible. And then there was sort of the more like structural side of creating the multilingual space. And so once my supervisor is a Zoom pro. She has a lot of experience by this point with Zoom and simultaneous interpreting in Zoom. And so once we were able to like kind of nail those logistical features, I was also able to share more kind of strategic ways of creating a multilingual space. So one of the things I suggested would be that in the next meeting, the presenter present in Spanish. And that way the English speakers would need to tune into the interpreting, because a lot of times folks don't think the interpretation is for English speakers. They think it's for the other language. And so that was really awesome because that got the English speakers using the interpreting feature, and the Spanish speakers, I think, were more encouraged to speak up because it was in, you know, the language that they were maybe feeling most comfortable in. But then the English speakers knew they could still talk too. And so everybody was in conversation with each other, which is exactly what we wanted. And it seems so simple, but when you experience it, it's really powerful and really awesome because you have people that maybe in real life wouldn't actually get the chance to have a conversation like that, especially around something that's so meaningful. And when a lot of these people might have actually a lot of similarities in their background, to be able to make a space where those people can actually be in conversation with each other is really gratifying and really awesome. And that was that was my takeaway from that experience. And we were able to repeat this success many times for many meetings. And everyone got really good at it. So, you know, it can take
Thank
practice,
you.
it can take time, but we did it.
Thanks so much. I know we're out of time. I will say that we have a link to our tip sheet on how we did that. If it's online, actually, if anyone looks up CalQuick UCSF, it's online, but I can, if anyone needs it, reach out to me. Thanks so much, Sarah.
Thank you.
Thank you, Sarah, and thanks everybody for joining us today. And we look forward to seeing people next week on Grand Rounds.
Great.